This is a case of Microspherophakia, and this boy, 15-year-old boy, was actually picked up from a blind school. His sad story, he underwent all these wasted blind years in a blind school, wearing a -20 whatever glass, which gave him vision of about half a meter. He could see just shapes and colors, hardly anything. And finally, we decided that we would take him up for surgery. We knew it's going to be difficult. This is how we went about it. This is probably one of the most time-consuming surgeries that I ever done. And here I am first fashioning my Hoffman tunnels. I plan to do a scleral fixated IOL in this case. I don't think this bag is fit for anything, and this surgery was done more than 12 years ago, before I actually started retrofixated IOLs and stuff like that. But anyway, this is a good option. So here I am creating one of the Hoffman tunnels. I think its tunnel is good. As long as you don't get too much bleeding, you are in a right plane. And 180 degrees opposite the other tunnel, and this should be done perfectly. You cannot muck around with these incisions. They have to be perfectly 180 degrees opposite to each other. Making sure that I have got enough of a tunnel. I don't want to be found lacking later. I then go ahead, put in a 2.2 millimeter incision, and put in 2 side port incisions as well. I am just using HPMC. I am tamponating the vitreous on the other side and filling the entire chamber with viscoelastic. I am now trying to puncture the anterior capsule. You can see how difficult it is to even get a puncture. Persisting. Finally, I have made a puncture and trying to. This is I changed the needle to a 27 gauge needle. The initial needle was a 26 gauge needle, and have managed to raise a flap. Just coming round, I won't be able to complete the rexus completely with the cystitome, that's for sure, but I am doing as much as I can. And you can see how difficult it is. So finally I put in some more HPMC and take my microrhexis forceps, catching the flap, and I am going to attempt to complete this rhexis with the forceps. Decide the axis is not too good from my side port, would be better from my main port, and that's what I do. And there, the rhexis is complete. Next thing would be to do a hydrodissection. It would be nice if everything just prolapses out. It would be much easier for me. Trying to get a cleavage, and there I got it. So once you get that, I've got the hydrodissection dissection as well. Go from the side put. I'm trying to bring this out. Yes, it's come out. I wouldn't want to phaco this in the bag. The bag is so unstable. I then take my 2.2 mm phaco tip and just aspirate that nucleus supracapsularly. Just watch how that bag is moving with. In fact, I'm at low vacuum and low aspiration rate, just 300 vacuum and around 25 aspiration flow rate, yet the bag is too unstable. The other problem would be we don't want any vitreous to present itself. There is some epinucleus still left, so I go after that. Get that out. I then take my bimanual. By now I have realized that the anterior highlight is quite stable. So that's one good thing going for me. And moreover, this, although a microspherophakia, although the zonules are loose, they are pretty strong enough to maintain the shape of the bag. So although I have toned down my parameters, I am able to slowly but surely remove the cortical material. Trying not to exert too much pressure, too much tension on the bag. I just switch hands and take out the cortex from the other side as well. And the one beautiful thing is the bag is going back into its place. So I'm happy about that. There is no way I'm going to use this bag to put any lens, and I have decided not to put a CTR as well because the bag is maintaining its shape. I'm just going to leave the bag there and put in an SFIOL. And now for the really time consuming part of the surgery, putting these scleral sutures and railroading them. So I'm just going 1 millimeter past the limbus. You have to make sure you go vertically down, then turn. Do not engage the bag, try to avoid the bag. That can be difficult. You have done it, and now from the other side to come with the straight scleral suture needle. Controlling that is extremely difficult. However, luckily I am able to railroad it. Once you railroad it, the rest of the stuff is easy. So you just bring out the scleral suture, take enough of the thread with it and put it on one side. Now I go about 1.5 millimeters lateral to this with my second scleral suture. Again going with my 26 gauge needle. The needle is a little robust, so it's very easy with the needle to puncture and to control. But the scleral suture is very long, very thin, and that becomes a problem to control. And you will see it in the second suture, although this is edited. Even then you can see how difficult it is. to control. And remember, there is a fragile capsule beneath. You don't want it being punctured by these sharp instruments. I'm trying my best to bring it around. I can easily go into the bag. So, trying to thread it into the 26 gauge needle and see how difficult it is. It just has a mind of its own, goes wherever it wants to. Anyway, I've finally done it. Once that's done, it's okay. Then thread it in and neatly bring it out. Now I am planning to put a rigid 5.2 mm lens as a scleral fixated IOL. I'm not planning to make my life more miserable by trying to put a foldable in here. So I've increased with the 2.8 and then with the 5.2, just slightly I've increased it. I take my Uthrata faucets and bring out both the sutures. I will have to cut this loop, and of course one side will be tied to one loop, the other side will be tied to the other haptic. Controlling this is a 10-oproline. Now we don't use 10-oproline anymore. We use mainly 9-oproline. This was 12-15 years ago to have done this surgery, and it's very difficult to handle this suture. You think it would be just easy to tie it to this haptic, but it's not. And you have to tie it and put it at the right place along the haptic. It does rotate when you put, so you don't have to worry. So I have put make more than 4 knots on the haptic. Don't make anything less than 4 knots. You can make 6, 8, whatever, but it should be more than 4. Otherwise it can open up. I have edited this a bit, otherwise the surgery would just be too long. Handling these sutures is very difficult. I then push in the IOL. I want to put this into the sulcus. I don't want it to engage the bag, and you have to put it in the proper orientation also. You should not allow the sutures to get entangled. There are so many things that you have to do in this surgery. It's a pretty tedious procedure, but at times it just needs to be done. So just picking up some of the slack on one side before I tuck in the haptic of the other haptic into the sulcus, that is under the iris. See that it doesn't engage the bag. Don't do any aggressive movements. This is the time that you have to have real patience. Do everything slowly, watch what's happening. Just pulling off the iris in case there is any sort of engagement of that knot with the iris. And now it's time to pull the sutures into the tunnel, and that's what I have made. The whole idea of making the Hoffman tunnel is to have these scleral sutures well within the tunnel, so nothing is exposed. And once you have the Hoffman tunnel, the advantage is you don't have to make scleral flaps, you don't have to do a peritomy, so that's the advantage. And it definitely aesthetically it looks far better. So I'm pulling out this suture. Obviously I have to cut out the needle which is at one end. There I have done it. Same with the other suture by its side. That needle also has to be taken off. Make sure these sutures don't get entangled with one another, and orient the sutures properly, otherwise you will get confused. I'm cutting off that needle as well. Pull this suture out, and now I'll just pick up the slack and slowly adjust. I've adjusted the IOL, it looks good, so I plan to tie off one side first. So initially just I'm putting one knot to orient it properly. And that looks very good. And here also make more than 4 knots. I have made some 6 or 7, I think. Finally, cut it flush, don't cut the knot, and tie it on the other side as well. Keep watching the pupil, watch for any fluctuations on the AC, watch for any IOL tilt. Doesn't look like there's any tilt, it looks like it's very well oriented, very well centered. And I can go ahead and square off my knots now. Finally just pull and cut so that the knot retracts into the tunnel. You don't want any exposed suture peeping out of your tunnel. It defeats the whole purpose. And once that is done, looks pretty good. Well, the last part would be to remove, obviously I have to remove the HPMC. I will put in some intracameral pylo and some intracameral antibiotic. And the pupil is very well centered. It's gone down because of the myocol I have used. And I did put a suture for the wound which I have not shown in the video, but anyway, with this I conclude the surgery. Thank you for your patient watching of the entire video.